Welcome to Around the Room, a podcast brought to you by the Canadian Rheumatology Association. Calling all rheumatologists, the CRA Room Review program is back on February 21st, 2025, and you won't want to miss this top-rated program. Room Review is a full-day virtual course that covers the latest in rheumatology with clinically relevant topics from leading experts. Open to both CRA members and non-members, registration opens November 1st. Learn more at room.ca. And now, on to our podcast.
My lab is very interested in really two aspects of systemic sclerosis. One is related to the pathogenesis of systemic sclerosis, and that has really two arms. And the other one is related to really understanding chronic fatigue syndrome in patients with systemic sclerosis. The other aspect of the research that I do that is not translational is more, I would say, clinical research. And this is really focused on microvascular assessments in patients with SARDs.
That's Dr. Mo Osman. He is an associate professor and rheumatologist with a focus in clinical immunology. He is the director of the Systemic Sclerosis and Microvascular Clinics at the University of Alberta. He is a clinician scientist who is interested in better understanding the pathogenesis of systemic sclerosis. He also uses point-of-care vascular devices for risk stratifying patients with systemic autoimmune rheumatic diseases. He was named in the top 10 research advances of 2023 by Arthritis Society Canada. That research discovered intriguing similarities between systemic sclerosis and cancer, and they uncovered a new biological marker for scleroderma. We are thrilled to have him as our guest on this episode of Around the Room. We will be talking about his research in scleroderma and connective tissue disease. Welcome, listeners. I'm Daniel Ennis, and a warm welcome back to my fabulous co-host, Dr. Janet Pope. Janet, how you doing?
Very well, and I'm really excited about today's episode.
Me too. I was sharing just before we started recording that I was running a little late, so I had to run all the red lights on the way home just to get here in time for this. So I'm excited as well.
And he's kidding. Don't worry.
Right. So Mo, welcome to the show. It's really great to have you.
Thank you very much, Daniel. Thank you for having me.
You're such an interesting kind of thought leader in rheumatology now, and it's always kind of nice to hear how people started, because I remember when I was in med school, I looked around and I was like, one of these people is going to be a world leader in something, but it was often hard to tell who that was going to be. So I would love to hear about kind of where you trained and how you got to where you are now. Can you kind of walk us down that path?
I honestly didn't know anything about rheumatology until my second year of medical school. I did one of those CRA studentships, which apparently work because I'm here as a rheumatologist. So there you go. And I went to my first ASM after this, and I saw a whole bunch of rheumatologists dancing, and I was sold. I was just saying, this is definitely for me.
I don't know who that would have been that you saw.
Hard to know.
I'm not going to mention any names today, but, there were a few esteemed colleagues on the dance floor. And since then, of course, I've been to a few ASMs, and this is one of the traditions.
And where did you do your training?
I did my bachelor's degree at Dalhousie in biochemistry, and then I moved out to Edmonton. And believe it or not, I had never been this far out west because I'm a maritimer. Did my PhD in immunology. Then I stuck around for med school residency and rheumatology residency. And then I did a postdoc in pulmonary hypertension and metabolism. And then I did a microvascular fellowship in Italy, in Genoa. And then I did another vascular fellowship in the Netherlands. Right?
Yeah.
How much time do you have?
Yeah. Mo, save a little talent for the rest of us, maybe. That's that's a really incredible trip across the world to gain all the expertise that you have around a topic that I'm not sure that everyone really even knows is an evolving area of science. I'm wondering if maybe your history is so fascinating, but maybe that's a good jumping off point to start talking about how you kind of got your research apparatus off the ground, and then we can actually get into the research. How did you start doing what you're doing?
Yeah, so research, as every clinician scientist will tell you, is a very challenging journey, especially in the beginning, because you're trying to kind of figure out which questions you want to tackle. For me, it was all about mentorship, and I'm being really honest when I say this. So my postdoc boss, he's a pulmonary hypertension doc, and he basically said, hey, you're a rheumatologist, why don't you study scleroderma? I honestly didn't know very much. I had already qualified as a rheumatologist, but I didn't really know much about systemic sclerosis at that time. So I started joining him in clinic and learning more about the disease. And I realized, this is a funny disease that we call autoimmune, but it's not really behaving the way we think about autoimmune diseases. During my postdoc, I kind of learned more about metabolism and how mitochondria are kind of important in inflammation, but also in everything pretty much that happens, whether it's normal or abnormal in the body. I very quickly realized that scleroderma was not so different from pulmonary hypertension at the cellular level. And this is why I kind of started looking at this initially during my postdoc, but then when I started setting up my own research lab.
Incredible. Janet, you've also and are actively doing a ton of research. Did you have a sort of similar journey with all the bonus extra training?
Right. So Mo's more trained than I am, but I don't have an undergrad degree because we could get into med school back in the day after a couple years of uni. And I did a master's while I was doing my fellowship, and I'm on the clinical side. So Mo and I talk a lot together because he's doing translational stuff. And if we can characterize patients and send samples, that never hurts. It helps crack some of the code. And we look at it in two different ways, right? I'm looking bedside and near now, Mo looking bench to bedside and back again. And I'm trying to help to contribute in some ways when you get back to the bench and ask these. We make observations, and I think what you've done, Mo, has been really quite a journey, and making the analogies of uncontrolled vascular dysfunction that leads to obliteration. We're used to things leading to atherosclerosis as they heal, or and other forms of narrowing, sort of stenosis, whereas this is really obliteration of blood vessels at the pulmonary arterial bed, and certainly at the nail bed, and in some kidneys and other organs, the heart even, in scleroderma.
We don't have that many basic scientists come on the show so far. Could you just walk us through what a day in your life, or what the week looks like? I'm curious how one can run a lab, which seems like its own Herculean task, and also be a clinician, and also have other hobbies. Can you can you take me for a walk there?
Oh, for sure. So this is a team effort. This is not in any way means just me. I mean, I have to say I have a spectacular, amazing team. So in the lab, my research coordinator is amazing. She's extremely organized, and she is basically what makes things go in the lab, for lack of a better word. I call her the glue of the lab. So whether students or postdocs are they need something ordered, or they need something organized, or she needs to get in touch with Janet, for example, or some of our other collaborators across the world, she makes sure things happen. She makes sure ethics are kind of rolling. So she is really the glue behind all of it, I think. As far as the breakdown, I always wanted to have a smaller lab. I never wanted to have a big lab, because I wanted to feel connected to the bench at some level, even if I'm not allowed to do experiments anymore. Because I mean, as Hanny, he mentioned this to me. He's like, my trainees call me biohazard. I kind of feel like I'm becoming this way now. So whenever I come to the lab, they kick me out because they don't want me to, disturb their peace, type of thing. But I've always wanted to have a small lab. I try to meet with everybody every week just to kind of see where things are, what I can do to help them, and just to challenge them a little bit. So especially as they kind of mature, The best example I have is I have a PhD student who's almost done. And I remember when she first started and where she is now, holy moly, things have changed dramatically. And now she tells me, I don't really need to meet with you anymore. Let's meet next week because I'm more of a distraction for her. So it's good. It's good this way. In the clinic, I'm very blessed with colleagues that I would say help me protect my time and help me focus. So I think so. So my colleagues are spectacular. I mean, they only send me referrals that I think I should see. I never say no when they ask me to see something that they need help with, but I have to say I owe them a lot. And of course, trying to kind of limit how much call you do as a clinician scientist is so important, especially in the beginning, because, time, you need time. Obviously, if you're not doing call, someone else is, which means that your colleagues are stepping in and they're the ones who are kind of, really doing all that extra heavy lifting for you.
Well, it sounds like they of course see your value as a researcher, and so it's a whole, as you said, it's a whole team that makes it. Teamwork makes the dream work. This is maybe not entirely relevant, but I can tell you the moment I realized I couldn't be a scientist, and that was in first year chemistry, when I connected my Bunsen burner to the gas and held the lighter over top, and I turned on the gas and a big spout of water shot out the top of my Bunsen burner because I hooked it up to the wrong spout. So so I think some of us are not made for the lab, but it's a really incredible place to work, it looks like. Maybe we can talk about your research then. What are kind of the big buckets of research or big categories that you're working on right now?
My lab is very interested in really two aspects of systemic sclerosis. One is related to the pathogenesis of systemic sclerosis, and that has really two arms. And the other one is related to really understanding chronic fatigue syndrome in patients with systemic sclerosis. The other aspect of the research that I do that is not translational is more, I would say, clinical research. And this is really focused on microvascular assessments in patients with SARDs. So with a focus on identifying patients with, what we call VDOS in the systemic sclerosis world, so very early diagnosis of systemic sclerosis, but also looking at other patients, for example, patients with dermatomyositis, other kind of overlap syndromes, and also patients with lupus. So the lab is kind of very focused, I would say, on three aspects, and then I am focused on with clinical trainees on the other aspect.
Maybe we can start with the bench work that you're doing. So we had kind of alluded, and you've just kind of mentioned looking at fatigue biomarkers. Can you kind of talk us through that? If you can tell us kind of how that works and how you figured that out.
So we're still figuring it out. So we still have a lot of work to do. But one of the first things that we wanted to do was really understand the contribution of mitochondria. So as I was mentioning, I postdoced and studied with one of my mentors who really is focused on understanding how mitochondria affect disease, particularly pulmonary hypertension. So when we started this work, we were really fixated on trying to understand how mitochondria are different. As any good researcher would, we reviewed what other people have done, and we said, well, what does chronic fatigue syndrome look like in idiopathic patients with ME/CFS, or myalgic encephalomyelitis chronic fatigue syndrome? And we started just reading and kind of creating in silico ideas and models related to this. Eventually, we actually started looking at changes that we think were relevant to mitochondria and specifically transcripts within the electron transport chain. What's really striking, though, is that we very quickly realized that chronic hypoxic stress is something that can recapitulate some of these changes that we were able to detect in the blood in the fatigue patients, but not the non-fatigued scleroderma patients. So then we really started focusing on this hypoxic stress. And where the data is right now is telling us that these patients with systemic sclerosis and fatigue really have a more profound systemic hypoxic state. And we're really trying to kind of pinpoint this. So we have a lot of data that supports this. And we just got a grant where we're going to be able to work with one of my good collaborators here in Edmonton, Mike Stickland. And the two of us are going to look at using exercise and exercise intolerance to really bring out this hypoxic stress signal, but also better understand the some of the biology that's happening at the cellular level.
So would this be like lactic acidosis and or even more micro changes than that?
So it's really interesting. So in chronic fatigue syndrome, people have already shown that lactic acid is higher in those patients. And we're literally in the middle of a metabolomic experiment where we're looking at various metabolomic changes that are happening in the fatigue patients compared to the non-fatigue systemic sclerosis patients that are age and sex matched. And what's really interesting, Janet, is that lactic acid, but also other derivatives that are derived from the electron transport chain are actually profibrotic, which I didn't know up until about maybe a couple of months ago. And further to this, what we've been able to show using the Canadian Scleroderma Research Group data, very early on, those patients who have severe fatigue actually have more progressive lung fibrosis early in their disease, but not later. So we're trying to kind of see if perhaps the patients who are fatigued have higher levels of these electron transport chain mediators, which we think are relevant to fibrosis. And then we're also trying to link this up with what's happening at the cellular level by doing some of these experiments in vitro in the lab. So it's pretty exciting, actually, in that way.
It's very interesting, but also terrifying because it raises the possibility that I might need to relearn some cell biology, which is a terrifying prospect. But that's a really interesting work. Someone had said this to me a little while ago, that certain diseases have a deeper biology. And I like what they were talking about was that you read a biology textbook and these are the facts so far. This isn't the be-all and end-all of disease and how things work, and that there are biologic processes that like we just have not characterized well enough yet. It is more complicated. It is harder to get at. And kind of interrogating as you are the way that the electron transport chain and mitochondria influence directly a clinical manifestation that we are notoriously bad at treating is so fascinating. It speaks to that kind of deeper peeling back yet another layer of the complexity of our diseases. Janet, I'm curious, like in your clinical practice, you see tons of scleroderma patients. Have you found that chronic fatigue is quite common among them?
Right. So I think it's really difficult to label chronic fatigue because I do think of it more as being idiopathic. And interestingly, our fibromyalgia patients, whether they have a CTD or a SARD or not, you know, the fatigue in those people with chronic pain and poor sleep, et cetera, is pretty overwhelming. But we have people without any generalized pain, such as, say, Sjogren's syndrome, that have overwhelming fatigue. Some are even work disabled from it. So when we move on to thinking about scleroderma, I've never really thought, I think this is chronic fatigue secondary to scleroderma. I think I've just sort of said fatigue. I don't understand because it's not always directly related, at least in the clinic, to disease activity. And it is true that the mean fatigue score we published on a long time ago of just follow-up scleroderma patients, all comers, is about 4 out of 10. But a huge range. Hardly anyone's 0, but there's 1s and 2s, and there's 9s and 10s. It's almost like two different distributions, not so fatigued and extremely fatigued. So the median or mean being 4 is sometimes a little bit deceiving. Sometimes it's so multifactorial, right? They're work disabled. They have chronic pain from their ulcers. They might have huge anemia from GAVE or erosive esophagitis, anemia, chronic disease, whatever. And they might or might not be hypoxic. Even in some people, even with moderate ILD, are already hypoxic, say with exercise or lying down or things like that. They're aspirating. So I think it's so multifactorial. So what Mo has looked at is actually something fairly profound, because if we think mitochondria, microvascular change, fibrosis, I would say, wow, that's like diabetes. That's like a lot of organ dysfunction where they basically get into fibrosis. But yet the idiopathic chronic fatigues patients, we don't see them as fibrotic in any way, shape, or form. They don't get sclerodactyly. Most of them don't have Raynaud's, probably about the same proportion as the general population, maybe slightly higher, but not huge amount of Raynaud's. So it's pretty interesting. And I think, that kernel of what you found might someday translate into the possibility of, there might be a treatment that we can do that could be, borrowing from somebody else, the exercise physiologist, with helping mitochondrial changes in muscle, etc. It might really lead to something that will help our patients.
Mo, I don't know if that's like a frustrating question for a basic scientist to be like, so then how do I fix it? It takes so much work to.
That's what we like.
But I am going to ask you that tough question. Has this given you what you have learned about scleroderma fatigue? Has that given you any kind of early insights into where that might take treatments?
Just to kind of echo what Janet was saying, so scleroderma fatigue is not the same as other SARD fatigue. It's very, very unique to scleroderma. And some of the biochemistry we've done in the lab has shown this. Scleroderma is special. Can we use this information to develop a therapy? Maybe. We don't know. So people have thought about kind of manipulating mitochondria through different ways. We haven't done this in the clinic yet. I think it's too early. Is this something that we want to do? Maybe. People have tried to use exercise as an intervention potentially. Theoretically, people have shown that it can change how mitochondria behave in people. So perhaps this could be an intervention. But honestly, I don't know. The only way we'll know is if we actually start doing those types of things and trying to show that there is a change over time, and we have biomarkers that actually reflect this change. And further to this, we've identified a few biomarkers which we think are kind of very relevant to this, which we only see in scleroderma fatigue. We don't really see them. For example, we've looked in lupus, we've looked in ANCA fatigue. We don't see it. So we think that, this is something that we can potentially use as a biomarker to help us really understand the biology, and eventually, hopefully, lead to something that's meaningful for patients.
Maybe now we can turn to some of the more bedside research that you're doing with point-of-care vascular assessment. Can you kind of describe what sort of procedures you're actually doing now?
So right now, I'm only doing nail fold video capillaroscopy. The plan is to marry this with what I learned how to do in the Netherlands, which is high-frequency sonography and photoacoustic imaging. That's what I want to do. That requires money, lots of money. So I'm working on that part. But the microvascular clinic right now is focused on essentially using video capillaroscopy, which is a very straightforward and simple tool to look at people's capillaries in real time. You can just measure the morphology of the capillaries, so different changes, morphologically speaking. But you can also take videos, I should say, of red cells going up and down the loops. And that also provides meaningful information.
Can you elaborate on that? How do you use it clinically? How is it helpful for the clinician assessing scleroderma?
So this was first described, actually, or most, I wouldn't say first described, I would say most prognostically described by actually one of our Canadian colleagues, Marshall Koenig. And Marshall did a very nice study where he basically took patients who had a positive anti-nuclear antibody and Raynaud's and asked the question, okay, so how many of those patients progressed to develop systemic sclerosis that was classifiable over the next 5 years, 10 years, if they had a scleroderma-specific antibody? And just to remind everybody, what those are the topoisomerase or SCL70, the anti-centromere antibody, antisense B is usually the one we like to see, a THTO antibody, or perhaps the RNA polymerase. And in those patients who had a microvascular pattern that is a scleroderma pattern per se, those patients had a very high probability of progressing to scleroderma, even if they didn't have any clinical manifestations. All they had was the antibody and Raynaud's. Whereas when both the capillary changes were absent and the scleroderma-specific antibodies were also absent, the probability of progressing to scleroderma was less than 2%, which tells you that, this is actually a very powerful and sensitive tool. So This is, I would say, where most of the data is for using video capillaroscopy. What else have we done? Well, other people like Vanessa Smith and Maurizio Cutolo have published studies related to how capillary changes are helpful in predicting ILD. Other people have looked, for example, Jerome Avouac's group in the French Scleroderma group have shown that capillary density and capillary changes can be helpful in predicting pulmonary arterial hypertension. So it's the systemic vascular remodeling that happens in systemic sclerosis. And then we've been collecting data in conjunction with our collaborators in Calgary, where we've been looking at capillary changes in response to stem cell transplantation. And there's no doubt in the responders that the capillaries pseudo-normalize, which is the only therapy I can think of in systemic sclerosis that actually helps this. The other thing we're doing is we're also looking at how this correlates with disease activity in dermatomyositis, and if this is potentially useful in patients who have lung changes related to dermatomyositis versus just dermatomyositis without lung changes.
Right. And I think if we were going to go right from the specialty clinic to maybe the clinicians who are the regular rheumatologists that see some systemic sclerosis for sure, but we all get referrals where Raynaud's positive ANA or older age onset Raynaud's, and older age and Raynaud's onset is not that old, maybe mid to late 40s or 50s at the oldest and above would be very atypical to get your new onset Raynaud's. And I think for most of us, doing capillaroscopy with, at the highest level is not ready for prime time, even though it can be predictive. I just gave a little course on how to look at neofold capillaries for the busy clinician. And so I'm giving a little plug for a free thing on your iPhone or your whatever phone you have. And it's called Magnifier. It's free. You can download it. It's on some of the iPhones. My iPhone's probably too old. And you can magnify with a light and take a picture, and you can upload it into your EMR. We also have the dermatoscopes. There's some jewelry loops. There's also things on basically on the internet where you can buy that will polarize and magnify, so the dermatoscope does, but a few other things. So there is stuff out there, because the absence of capillaries at least some degree of magnification is better than seeing hemorrhages or dropout. You don't see at the capillary level, but you can see the macro changes of when you have this hypoxic stuff going on. There's hypertrophy and hyperplasia of what's there, and eventually it drops out. It can't do it anymore. And then you can get into wild capillary patterns, kind of spiraled and funny things over time and disorganization. So I think what you're doing, Mo, is really helpful, and it is clinically predictive. I think it's not feasible for most of us in a Canadian busy clinic, but the learnings sort of start going down the pike so that we can at least say, okay, the prognosis, if you're ANA, say centromere, you have Raynaud's, you're 58 at onset, 1 in 3 will have systemic sclerosis in the next 5 years. But you'd like to also say, well, who do we rule out too? And even having abnormalities doesn't mean that. It just really enriches the chance. And if we ever have preventative treatment, we don't even have preventing CCP positive arthralgia from getting RA yet, which is a lot more common, right? But if we ever get into preventative personalized medicine, which I think we will someday, these sorts of then tools will be extremely helpful. So that's where I think that your research is helping to lead us. It's like, and then is there an easier biomarker that helps to correlate where you wouldn't have to do capillaroscopy annually or over time when things change? And I think that's what will come from some of this. Am I on the right track, Mo, or do you think really we should all be doing this?
I think it depends. I think if you're a rheumatologist that has a busy practice, I don't think it's feasible, especially when you can get a pretty good specificity. So specificity is over 94% using a derm light or using one of those iPhone devices. But I think for people that have a dedicated systemic sclerosis clinic or SARD clinic, I really think it's a worthwhile investment. And the reason why is because the sensitivity for the other devices is not very good. It's only like 62%, 63%, something like this. So further to this, one of our colleagues, Tracy Frecht, who you know well, I know, she's done studies comparing some of those various iPhone kind of devices. And she's shown that unequivocally, they're not good. So for their sensitivity per se. So I think if you have this kind of dedicated clinic, I think this might be a good thing to consider. As far as telling us about the biology, I think I completely agree. I think we really need simpler biomarkers and tools. So one of the things that I was not aware of when I was in the Netherlands was the so-called gold standard, which is the cooling test. I don't know if you guys are familiar with the cooling test, where they essentially put people's hands in ice and they drop the temperature by 4 degrees every 10 minutes. I personally had never seen this done before. It's amazing how predictive that test is. Obviously not feasible in the busy clinic because you have to have this poor patient there for about an hour and a half. But it's actually interesting to watch, talk about biomarkers. And what they were doing, which I think is really cool, is that they showed that exposure to cold in these patients with scleroderma was actually enough to trigger inflammation. And they showed this very nicely in contrast to patients with idiopathic Raynaud's phenomenon, where they were not able to see those inflammatory markers go up. So it really tells you that cold exposure and that stress that cold kind of brings to patients with systemic sclerosis is a little bit different than other patients. And it tells you that we really don't really understand this, but potentially there are opportunities for developing biomarkers for these patients.
Right. So do you think it's a spectrum from primary idiopathic Raynaud's to these pre-autoimmune Raynaud's where they've got some abnormal capillaries to right full-blown systemic sclerosis? Because whenever they do biomarkers, it's almost like an idiopathic Raynaud's, a little bit of endothelial dysfunction, VCAM, ICAM might be off, TGF-beta might be off a wee little bit, not much. And as you go down the food chain of more into more what we'll call actual disease of labeling systemic sclerosis, and then going from a patient who's limited to a different subset who have more fibrosis in the diffuse subset, you basically see more and more abnormalities, sort of differences along the way with probably a few key hits or changes that put people along the way with the genetic predisposed background, I suppose. I kind of want to talk myself into it being a spectrum because, you know, Raynaud's is so common and yet getting systemic sclerosis is not common. ANAs are a dime a dozen, including in Raynaud's people, but the specific autoantibodies are pretty uncommon.
So in a way, it's a spectrum. I completely agree. So, you know, the way I look at it is if you take patients who have the specific antibodies, and then if you look at the progression, let's just look at the capillary progression of these patients. They still don't progress in the same kind of way. The slope of the curve is not the same. This tells you that clearly there are things about this particular patient who is a progressor that make this person a progressor, and there are things that are not so progressive. The other thing is this something unique to Raynaud's phenomenon? The answer is no, it's not. One of the things that I've been kind of dabbling with in the capillaroscopy clinic is I've been looking at patients with HHT. So HHT, most of them have TGF-beta problems. And as you guys know, TGF-beta is the so-called prototypical profibrotic, in quotation, cytokine that we have. And what's really interesting is that those patients have very, very abnormal capillaries. So more abnormal than the most abnormal scleroderma capillary pattern I've seen. And most of these patients don't have Raynaud's. So it tells you that this actually, you know, it may not necessarily be related to the Raynaud's, but perhaps if you have the Raynaud's with the vascular damage and the inflammatory reaction, then you see some of these spectral changes.
And their blood vessels are crazy, right? HHT for the hereditary hemangioma telangiectasia. They've got wild telangiectasia, sort of, some of them, not all, but like our worst scleroderma patients that have 20 years disease duration that have like 1,000 telangiectasia on their anterior chest. It might be very much the TGF-beta in them is acting more like an abnormal blood vessel growth factor because, yeah, they don't have Raynaud's, at least an increased incident, and they don't have sclerodactyly. Because I have a HHT family that all have gout as well, so I see them. So they're coming in, and so I'm always looking. I'm showing the trainees. This is a wild scleroderma type pattern of a telangiectasia, but this is obviously, and it's in the right distribution where our patients get it. So yeah, so I think, you know, you're really you're sorting out a lot of different questions. And again, some we don't know yet how we're going to get a clinical relevance, and other ones are going to help predict for our patients who's going to be one we worry about at night and who's going to be someone you just see annually and eventually say, out of here now, your blood vessels have stayed good, your anti-centromere is just, there, and maybe some year you'll get something and maybe not.
Mo, that's super fascinating research. And as a researcher, you really have your eye on the future of rheumatology, whereas I feel like I'm just kind of trying to make it through the day.
No, Daniel. You're impacting on vasculitis all the time, and by doing this podcast.
Sure. Well, Mo, thank you so much for coming on the show. It was really great to talk to you. I will continue to follow your career with great interest and expectation. We have 2 clinicians here in Vancouver who have just started doing nail bed capillaroscopy, Hain Kim and Kun Wong. We're starting to kind of wrap our heads, the clinicians, around how valuable it can be as an additional adjunct tool to what the info we already know. So thank you again. And Janet, of course, thank you as well. And hope to talk to you soon.
Thanks for having me.
Great. Thank you. Bye, Mo.
That's it for this episode of Around the Room. For questions, comments, and future episode ideas, email us at info@room.ca or tag our Twitter account with your question at CRASCRRoom. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. And share this episode link with your colleagues. It helps these interviews reach as wide an audience as possible. Until next time, with Janet Pope, I'm Daniel Ennis. Thanks so much for listening.